Good morning, everyone. Thank you for the kind invitation in your meeting. Sorry, because it's not possible for me to be with you, but I would like to send you this presentation on my strategy in front of failed instability surgery. This is my conflict of interest. So this is a summarized outline of this presentation. We talk about anterior instability, what is a failure, the etiologies, and the treatment and the strategies that I use for my patients and the results. So when you talk about failed instability surgery, sometimes you talk about painful shoulder, you talk about stiffness, and sometimes the patient is not able to return to the same level if it's athlete. And another category is a recurrent subluxation or recurrent dislocations. And it's important sometimes to look for a rotator cuff tear, particularly for old patients, a slap lesion, or examination of the laxity, because sometimes there is a Ehlers-Danlos syndrome. So, the main etiology of the failed anterior instability after surgery is a recurrent trauma. In 59%, a new trauma would create a redislocation. So, if we analyze the risk factors to recurrence after Bankart repair, you have patient's factors. If the patient is very young, less than 20 years old, 7.7% of risk. If it's older, 2.8%. If there is a male, the risk is 90%. If the first dislocation is less than 22 years old, or depends on the number of previous dislocation, depends on the number of previous operation. So sometimes you didn't do the good diagnosis regarding the bony lesion, and you do a Bankart repair, but you have an anterior glenoid bone defect, you have a bony Bankart, you have an erosion of anterior rim, and this is risk factors to recurrence after Bankart procedure. The humeral defect, sometimes is a very large defect, more than 30% of articular surface, and in this situation, even there is no lesion of the glenoid bone, you have a risk of redislocation after soft tissue repair, Bankart and remplissage. Sometimes you have a bipolar loss of bone. You see this patient with a Hill-Sachs lesion and anterior avulsion of the glenoid anterior rim. You have an engaging lesion. This is described by Burkhardt a long time ago in 2000. And you see on the left side, in abduction, external rotation, and retropulsion, you have a risk of anterior dislocation in this situation. And the concept of track-on and track-off, reported by Yamamoto and Itoi, and secondary by Di Giacomo. It's important to define the glenoid track. This is a contact in abduction, external rotation, and retropulsion between the surface of the glenoid and the surface of the articular surface of the head. And we measure the width of the glenoid, and this is 83% of the diameter, less than the lack of bone anteriorly. So, if the width of the glenoid is inside if the Hill-Sachs is inside the width of the glenoid, this is on track. If the Hill-Sachs is outside the glenoid width, is off track. Off track is a risk of engaging lesion. So now I do systematically a 3D reconstruction to measure on track and off track. Another point is the laxity of the capsule. And sometimes there is no labrum lesion, but there is a capsular redundancy, there is an intracapsular lesion. We have to look for a posterior inferior lesion after a Bankart or a Hagel lesion. On Hagel lesion, if you do a Bankart, you have a risk of recurrent dislocation. Sometimes the technique of Bankart is not good. You don't respect the academic rules. It's important to have a bump effect to repair the labrum and to medullarize a little the labrum. It's important to use a lot of anchors, but anchors between 6 o'clock to 3 o'clock or 7 o'clock to 3 o'clock. And normally I use 3 to 5 anchors. Sometimes there is a suture failure. You don't do a good diagnosis of the ALASAP lesion. Sometimes you repair but too medial, and sometimes you don't do enough retention of the glenohumeral inferior ligament. We want to avoid these technical errors when you do a Bankart repair. Pascal Boileau did a lot of Bankart repair, and even there is bony lesion. And after analyzing of this big series of 132 patients, he describes the EASY score. This is the index severity and stability shoulder. And he analyzed the age, the competition, the force in abduction, external rotation, the degree of hyperlaxity on AP X-rays, the size of the heel sacs in external rotation and the glenoid bone loss. And after analyzing this series, he proposed that if the number 3 is a key point, unless number 3, he proposed a soft tissue Bankart, and more than 3, he considers that the bone graft is necessary. So, sometimes the patients have a Latarjet procedure as the first operation after recurrent dislocation of the shoulder anteriorly. And you see that sometimes there is complication. It's not a so easy operation. Even you do open or arthroscopic technique, it's not so easy. And sometimes you have a coracoid process which is too medial or which is too lateral. And there is a malunion, there is osteolysis, there is avulsion, there is a conflict with the screw, there is many complications. And sometimes in a series you have 20% of complication after Latarjet procedure. If you have a significant bone loss, off-track lesion, technical error, or engaging lesion, in my practice, I do Eden-Ibinet. I do a graft with a iliac crease bone graft anteriorly, and I fix with 2 underbutton by arthroscopy technique. This is an example here. You see that the bone graft is too medial, maybe is too inferior. I did a bone graft with iliac crease. I did not remove the screw because sometimes the screw is very difficult to remove. Sometimes the screw is bended and it's very, very difficult by arthroscopy, even by open. And I do Eden-Ibinet with a fixation with 2 cortical underbutton. And you see the result of this patient after 1 year. So with Natalia, and I think for a great job, we analyzed the 17 patients of Eden-Ibinet technique with a more 3 years follow-up, and you see that we had 94% of stability, 88% of patients satisfied. So iliac crease bone graft was healed in 94%, and only 1 patient had the recurrent instability, and we revised this patient. So this is a technique that I would like to promote for you. Eden-Ibinet by arthroscopy with a cortical button. We don't open again the subscapularis. We don't touch. We go through the rotator interval, and with the technique of underbutton is very easy. We don't do the dissection in the medial part, and if it's possible, I repair the labrum and I do a Bankart repair. So For me, the cortical button, 1 or 2, 2 is better, is very useful in this situation because you can use even you don't remove the screw, and sometimes the screw is very difficult to remove. My first conclusion regarding failed anterior instability, I think that there is no article or no study has clearly established a decision, because the decision depends on many factors: the age, the type of sport, the etiology of failure, the experience of the surgeon shoulder, the patient's wishes is very important, and the guarantee to do a new operation, the joint laxity, and depends of the damage of the glenoid, of the humeral, damage of the cartilage, and depends of the healing of the previous operation, healing bone of the previous operation. So, my first conclusion is always a difficult challenge. But the first point, the first message is don't forget hyperlaxity, infection, stiffness, rotator cuff tear, slap lesion, nerve lesion. And sometimes, if you remove the material, it's not complicated operation, is enough. The second situation, if you have a bony lesion, you have off-track lesion. On my best operation in this situation, this is a head and net by arthroscopy with on the button. And if I can repair the labrum, if I can repair the capsule, I will do it. The last conclusion is that if you have no bony lesion, but it's very rare, it maybe in my experience is 10% or 15%, you have on-track lesion. I try to do a new Bankart by arthroscopy, or a new Bankart on posterior superior plissage, but we know that soft tissue repair with the long follow-up, there is a risk of recurrence. It's the reason why my indication is maybe less than 10% of soft tissue procedure in failed anterior instability. Thank you a lot, my friends, for this meeting, and I invite you to participate in Paris in July in the meeting focused to shoulder arthroplasty. Thank you very much.
So as we cannot ask any questions to Philippe, maybe one question for Manos, or I don't know if Marco's still here. Is the ALSA procedure a good alternative for revision cases? Can we have a mic for Manos, please? It's a big way around because he's there. No sound.
Now? Better? No? Yes. So, I think from the talk of Clara Azevedo in the morning and from the talk of Marco Maiotti, they use these procedures in the revision cases. In fact, for me, in revision cases, I'm very selective to do a soft tissue procedure again. But there are cases, and it was an example in Pietro Randelli's talk in the morning that was an operated young man, 18 years old, and he reoperated. He has a redislocation 20 years later, and he did a soft tissue procedure. So yes, this is a case, but in the vast majority of the cases for a revision, I go for a bony procedure. I'm very selective for soft tissue procedure in revision cases.
As we're doing with the Latarjet already a split of the subscap, would that be a concern to use the upper part or even a contraindication? As we already splitted the subscap longitudinally, would it be a contraindication to do the ASA or not really?
For the ASA? No, not really. It's not my concern because we have done some second look arthroscopies. We have the miniscope, the nanoscope, and we have used it to see how the subscapularis is healed. And there is a very nice healing without having any anatomical problem. So I don't believe it is a concern for me because this you do a denotasis in the glenoid and you have a dynamic factor. So every time you do external rotation, the subscapularis, the upper part of the subscapularis, limit the head to go anteriorly. So I don't believe that it has some problem, but I don't know after 20 years, let's say, if there is some insufficiency in subscapularis, but in our follow-up, which is we started to do this in 2017, so it's about five years. We haven't seen any, but it's probably too early to have a conclusion about this. Do you consider that it may be some insufficiency of subscapularis due to this procedure?
Well, you've got the experience. I haven't got the experience. You've got the...
Theoretically, you believe that it may be something?
Well, for those who are not familiar with the procedure, it's still kind of a concern, I think. For those who are familiar with it, it sounds all normal, but for us, it's still a bit weird. So that was my question, because you're using twice the tendon or working twice at the tendon. So that was just the question, actually, and a bit the concern that I have for the function of the subscapularis.
My concern is we have one revision case because we put the sutures too medially. So this patient has problem in external rotation, but only these patients, and due to this. And we have revised these patients, the only one that we reoperate about this. So I think if you do it properly, if you don't have some technical errors, I don't have some special concern.
Well, thank you. Any other questions to maybe other faculty members here concerning Dr. Valenti's topic?
You finish this session on the next one now.
Thank you.
Thank you.